Good afternoon, and thank you for joining us today. Before we begin, I would like to note that the views expressed in the written conference materials or publication and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide, please. My name is Manny Stiegel, and I have the privilege of serving as the project coordinator at Change Matrix for SAMHSA's 988 Crisis Systems Response Training and Technical Assistance Center that is operated by Altorum. Now, we'll take a moment to ensure that everyone in the audience is ready and familiar with the technical aspects of the webinar. I will turn this over to my colleague, Kaylee, to walk you through the webinar interface, including how to submit questions and other technical information.
Thank you, Manny. As you will see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities, and you will see the interpreters are spotlighted throughout the presentations today. If you need any technical support during today's webinar, please reach out to me using the Q&A function, and I will address it for you. Lastly, if you have any questions for presenters during the presentations, please enter them in the Q&A area, and we will address them as time allows after the presentations and during office hours.
Thank you, Kaylee. We will now turn it over to Elizabeth Waitzig from Change Matrix.
And first, I have to unmute myself. Welcome, everybody. We are so happy to have you here at our introductory inaugural event as the TA Center for Embedding Equity in the 988 Crisis Response System. We are thrilled with the number of people who are here today. There are 550 registrants today, and that tells us that there's a lot of interest in how we embed equity throughout the 988 Crisis Response System. So I just want to tell you a little bit about what you signed up here for today. The first thing that we're going to do is we're going to hear a little bit about the TA Center, and then we're going to hear a little bit, we're going to hear some messages from representatives at SAMHSA. We have some content to offer you, some respected experts in the field who have a lot to offer us in terms of what we need to be thinking about as we're embedding equity in our crisis response system. We have an opportunity for you to share some of your thoughts with us on something called a thought exchange, which I'll say more about later. But be thinking as you listen today about conversations that you think you might be having, might be needing to have in your community, state, tribe, or territory about embedding equity in your crisis response system. After all of those things, there'll be an opportunity to ask some questions of our experts, of our content presenters. So be thinking about what you might want to know. And some of you submitted some questions ahead of time. So we've made sure that we've sent them to the presenters as well. We'll do a little bit of a wrap up, but don't go away, because after we wrap up that portion, which will be about the first 90 minutes, we really want to encourage you to stay for the office hours. And the office hours are an opportunity for you to ask specific questions of SAMHSA and their support of embedding equity in the 988 system. So hope you have a beverage, get comfortable, stay with us for a couple of hours, and really think about this very important work that we're so pleased to be able to support as part of our TA Center work. And next slide, please. I do just want to say a couple words about our TA Center. The first thing that you should know is that it's a conglomerate of organizations. So Altorum is the prime, and they provide a lot of the infrastructure and support for the TA Center. And they invited W2 Consulting and Change Matrix to partner with them on this very important and very complex body of work. So how do we go about doing that? You'll see some things on the next slide about how we believe that we're going about doing this work. First of all, we are resting on SAMHSA's historic support. SAMHSA for a very long time has been invested in and committed to building systems for all populations, for diverse populations, making sure that those those who have not had access to appropriate services in the past do now moving forward. So there's there's also a longstanding commitment to funding technical assistance centers and centers of excellence to support the work of the field. We're so pleased to be among them, and we're also pleased to be connecting with them, knowing that it is complex work, and we want to make sure we're partnering among the TA centers. We as TA centers, as technical assistance centers, are dedicated to assisting the field, meaning all of you, and effectively building systems that are tailored to serve diverse populations. So we're very pleased to be in that role now. And on the next slide, we'll focus a little bit on SAMHSA's response training and technical assistance center. The mission, a core mission, is fostering support for diverse communities. And you're going to hear a little bit more about this later, but just know that we have been thinking about the focus of embedding equity as a scaffolded set of opportunities. So we want to make sure that we're doing some knowledge building, skill development, offering opportunities to support strategic planning, and most important, implementing the crisis response system. And this webinar is the start of scaffolded sequence of opportunities to make sure that equity is embedded all throughout those things, from the knowledge building to the skill development to strategic planning to implementation. It is done with a focus on equity and a focus on supporting diverse communities who may need behavioral health crisis support. Next slide, please. So we also, as TA centers, believe that not only are they supporting us, but we're supporting them, and we're supporting their commitment to equity here. And SAMHSA's commitment to equity includes a cross-cutting approach to ensure that it's woven into every initiative provided by SAMHSA, and it's at the core of all of the work that they do. And they have a specialized team, and you're going to meet some of them, that are committed to embedding equity across all aspects of the Training and Technical Assistance Center and all aspects of SAMHSA. So some of the examples of this are cultural competence resources and training, inclusive community engagement strategies, and an intersectional approach to crisis response. One more slide on the TA Center. We just want to let you know that, as I said before, that this is the first of many. And so what you're going to hear about in a little while is how do you gain access to the learning community or learning collaborative. We're setting up a learning collaborative that will start this month, and we're taking applications for folks who would like to be a part of that. And down the road in this presentation, we'll put a link in the chat and a QR code if you want to access the application. Also, on March 18th and March 19th at SAMHSA's headquarters in Rockville, we'll be convening a group of folks who are interested in thinking about their equity journey in a very practical, intensive way, and knowing that everybody's at a different place along their journey. It'll be an opportunity to hear from experts in the field, an opportunity to engage in peer conversations, because we know that you learn so much from each other, that'll be an opportunity to do that. But it also informs the work of our TA Center and of SAMHSA's office, so that we can make sure that we're being responsive. So look forward to more information about the Learning Collaborative and the convening happening this spring. All right, so on the next slide, you're going to see 4 very distinguished people who are part of SAMHSA's leadership, and you're going to hear from all of them, all of these wonderful people. I am going to first introduce Monica Johnson to say a few words. Monica is the director of the 988 and Behavioral Health Crisis Coordinating Center. She is a former interim commissioner for the Georgia Department of Behavioral Health and Developmental Disabilities. So she's been in your shoes if you were a state leader. She has extensive experience in executive leadership and program development, and has managed successful implementation and oversight of a number of federally funded initiatives. We are so honored to have you here with us, and welcome.
Thank you, Liz. And thank you to the participants for taking the time out of your very busy day to be engaged and connected in this very important topic. So I just want to start with gratitude and just thank you all. So I want to officially welcome you to our very first webinar on our quarterly 988 Equity Webinar Series. We are so excited about the extraordinary opportunity to initiate important conversations, highlight experts, and share helpful information, resources, and models to promote equity throughout the behavioral health crisis system. As you know, SAMHSA has a bold vision for the future of behavioral health crisis care in our nation. It is built on a belief that everyone struggling with mental health and substance use should have someone to talk to, someone to respond, and a safe place for help. Since its July 22 launch, 988 has received approximately 8.1 million calls, texts, and chats in total. But as we continue our work to implement the 988 Lifeline and expand and strengthen the crisis system nationally, we are deeply aware of the importance of equity and committed to finding substantive, effective, creative, and restorative ways to embed equity throughout the crisis system nationally. The 988 and Behavioral Health Crisis Coordinating Office envisions that all populations, regardless of demographics or unique intersectionalities experiencing crises, should have someone to talk to, someone to respond, and a safe place for help. This aligns directly with SAMHSA's vision and inclusion of equity as a core principle in our strategic plan. We embrace this vision fully as we see equity as being critical to bringing us closer to the goal of providing quality and affordable behavioral health crisis services for all. Over the past year and a half, we are so very proud that we have taken intentional, concrete, and necessary steps to make the 988 Lifeline accessible and meaningful for a number of diverse populations. We have improved the quality and the responsiveness of our crisis contact center workforce for priority, underserved, and high-risk populations by doing the following. We added Spanish text and chat services where Spanish speakers in crisis can reach trained, culturally competent crisis counselors. Specialized call, text, and chat supports for LGBTQI+ youth and young adults under the age of 25 has been expanded. The addition of American Sign Language or ASL and video phone services for people who are deaf or hard of hearing and for whom video phone via ASL is a preferred method of communication. And dedicated and culturally competent services for American Indians and Alaska Natives. All of these demonstrate ways in which we have worked very hard to improve equitable access. We also have Language Line Solutions, which has existed for some years and provides translation services to callers in over 240 additional languages. We plan to continue this work while also expanding our focus to the crisis system more broadly. We recognize that we have a lot more work to do, but we are up to the challenge and this charge. We invite all of you committed to this work, just like we are, to join us in this journey of realigning, recreating, and reimagining the possibilities in terms of embedding equity in the crisis system. While we are committed to opening doors and expanding access to care to those who are at high risk and most disproportionately and adversely impacted, our focus and destination is a place where we restore and sustain hope, healing, access, and resources for everyone in our crisis system. Again, thank you so much for taking time out today to be connected, to have open ears, open hearts, to really talk about how equity should be informing the work that we are each doing. We cannot continue to talk about this from a place of philosophy, but from a place of action. And so I hope that today is the beginning of concrete ways in which we can all drive this message together. Equity is critical to the work that we do if we truly want to transform the way we do behavioral health care in this country. Thank you so much. Liz?
Thank you so much, Monica, for your words, for your commitment to equity, and for the invitation for us to join you in taking action to embed equity. We really appreciate that. I'd like to take a few moments to introduce a colleague of yours. Lark Wong is a senior advisor in the Office of the Assistant Secretary of Mental Health and Substance Use. She is the director of the Office of Behavioral Health Equity, otherwise known as OBHE. She has 35 years in behavioral health at the policy, research, and practice level. She has been faculty at the University of California at Berkeley, Georgetown University, a managing director at the American Institutes for Research, and a clinical practitioner in community mental health. Lark has led efforts to advance equity and eliminate disparities throughout her career, and she provides national leadership on mental health and substance use policy, trauma-informed approaches, and justice system involvement reduction. And we are so pleased and honored to have you, Lark. Welcome.
Thank you very much, Liz, and thank you to Monica, Laura, and Jill for including my office on this first webinar. I'm honored to be part of this discussion. As you've heard, I am the office director of the Office of Behavioral Health Equity at SAMHSA. And this office was created as part of the Affordable Care Act, actually, in 2010. The mandate of our office is to ensure that everything we do at SAMHSA, grants, grant making, technical assistance, contracts, building new delivery mechanisms such as 988 and the crisis response systems, that they are all accessible, appropriate, and acceptable to underserved, often marginalized communities who've often had traumatic experiences at times, with our service systems. I applaud my colleagues at the 988 office. Launching the 988 number and the crisis response network was a landmark day, I believe, in crisis services, and an extremely heavy lift that they have done with just tremendous grace and thoughtfulness and deliberation. And I also applaud them for addressing equity issues right from the start. The issues for underserved populations are rarely at the table early on, whether it's newer medications, cutting-edge interventions, innovations in treatment. It often takes a significant amount of time before the unique challenges of these particular underserved populations are addressed, and the issues around trust and engagement are actually discussed and put on the table. So as you think about it, what does embedding equity in crisis systems really mean? And I think you heard from Monica and also from Liz on how they're approaching embedding equity in all aspects of the 988 and crisis response systems. One of the things that my office has as their core principle is making sure that we hear from the voices of communities, and the communities that we are focused on serving are those that have been underserved or marginalized historically. Some of the questions that we hear from the community around 988, as they're beginning to get more information and understand this particular and critically important service, is we hear questions such as, what is the difference between 911 and 988? When do I call each number? Will I be locked up in a psychiatric unit if I call 988? Will my children be taken away? Something that people in some of these underserved communities have had fears about in terms of calling 911 in the past. Will my children be taken away? Should I call 988 if I think my child struggling with substance use has overdosed? Can I trust 988? How does it actually work? So we hear questions, we hear positive and critically important stories and outcomes. And as Monica has said, the outreach has been incredible, and the number of callers to this date has beyond, I think, any of our expectations at SAMHSA. But how do we really ensure that this critically important service is made accessible and acceptable and understandable to communities and members of the communities who are not always involved in the decision-making and the creation of new and effective services? So I think you're going to hear more about that today from some real experts in terms of really understanding how different communities from different cultures, from different points of access, really understand what help seeking is about and their cultures, stigma issues, how that either facilitates or gets in the way of really getting access and accessing behavioral health services, and especially behavioral health crisis services. Before closing, I want to share a real quick story with you. When I was seeing clients in California, I lived in the San Francisco Bay Area, worked there for about 10 years. I was referred an elderly Chinese couple. They had an adult daughter with a serious mental illness, which they didn't really understand, and who they tried to keep at home, thinking if they gave her loving care at home and a good diet, that she would get better and she would be fine. Finally, after several months, they could no longer manage her behaviors, and they called 911. The police arrived, and she was eventually taken away. Due to language issues, the parents couldn't readily communicate, so they didn't know where their daughter had been taken. In the days after, they walked frantically from hospital to emergency rooms in the city, trying to find their daughter. But due to privacy regulations, no one could tell them if she had been admitted to their hospital. So as we learn what it means to embed equity in 988, I trust we will have no more stories like this. Navigating a crisis system is difficult enough, but when culture, language, fear of the system, not positive interactions with the system previously, the tasks become even more difficult. And I'm really grateful to my colleagues for holding listening sessions, webinars, bringing on training and technical assistance, and grappling with these really critically important issues. So I thank you very much for having the opportunity to share a few thoughts on your inaugural webinar today. And I look forward to having my office continue to partner with you all at 988. I also want to thank all the participants who have taken the time to call into this webinar today as well. So Liz, I'll turn it back to you.
Thank
You
you.
so much.
Thank you so much, Lark. And thank you so much for reminding us how important personal stories are, that they give us such good information about what folks are really experiencing and what we need to think about and consider when we're providing support, in especially at the beginning, as you said, that this is the beginning of creating this system. So thank you very much, Lark. We appreciate your time. We appreciate your wisdom. And now I'd like to introduce Laura House. And Laura House is somebody that we've gotten to work with very closely because she is the Equity and Engagement Lead for the 988 and Behavioral Health Crisis Coordinating Office in the Office of the Assistant Secretary. Laura has had extensive federal career experience in strategic planning and program evaluation and research and a variety of other roles, which makes her uniquely and exquisitely well suited to be leading this effort. Her previous roles are as the Region 3 Regional Administrator for the Administration for Community Living, representing the administrator. She holds a PhD from Howard University, is a licensed clinical social worker, an adjunct professor, and an absolute pleasure to work with. Welcome, Laura.
Thanks so much, Liz. Good afternoon, everyone. I'm so excited to know that so many people are interested in this topic and see it as so critical. I am, as Liz mentioned, the external engagement and equity lead for 988. And I just want to say that I echo what Monica and Lark expressed so poignantly earlier. Equity matters, and we know that it matters because it acknowledges disparities and their disproportionate impact historically and now. Next slide, please. It addresses systemic factors, social determinants of health, and negative consequences. It matters because it shifts the dynamics and disrupts the cycle of inequity. It matters because it rebalances and it redirects services and resources. It matters because it restores hope and healing for all. Next slide, please. So you may ask, where are we heading with our equity work in 988 and our broader equity work in the crisis continuum, crisis response system continuum? We're heading on both a journey and to a destination with a clear end in mind, but we fully recognize that it's a process that will take time. We're heading to a space where we can have a multi-directional impact nationally, within states, local areas, federal and non-federal entities, SAMHSA, and even within our 988 office. And we're heading forward supported by resources, some resources, community input, as Lark mentioned, experts like the two that we have today with us, joining us to offer insight, models, tools, training, collaboration, and technical assistance. Next slide, please. And where do we ultimately want to arrive? We want to arrive at a place where, as Monica mentioned, every individual, regardless of race, age, ethnicity, gender, disability, socioeconomic status, sexual orientation, or geographic location, can access high quality, affordable, and accessible crisis behavioral health care services and support. So we thank you for joining us today. Sit back, listen to our experts. Please, you are experts too, so we want you to also share, ask questions as we move our equity work forward. Now, with this in mind, it's my pleasure to introduce our guest presenters for today's webinar. Our first presenter is Dr. Vivian Jackson. Dr. Jackson brings extensive expertise in cultural competence and diversity to her role as faculty for the National Center for Cultural Competence at Georgetown University's Center for Child and Human Development. With a rich background in providing training and consultation for various federal, state, and local programs, including those funded by SAMHSA and HRSA, she has significantly contributed to advancing cultural competence and social work practice. Even in semi-retirement, Dr. Jackson continues her impactful work, serving on task forces and leading initiatives aimed at promoting racial equity and fostering dialogue on ending racism at both national and local levels. I'd like to turn this back over to Liz to introduce our Division Director for Crisis System Transformation first, and then following that introduction, we'll hear from Dr. Jackson. Liz?
Yeah, thank you. It is my distinct pleasure to introduce to you Jill Mays. Jill Mays is the Division Director of the Crisis System Transformation and 988 Behavioral Health Crisis Coordinating Office at SAMHSA. She leads two pillars: someone to respond and a safe place for help of the 988 Crisis Continuum. She is the former director of the Georgia Department of Behavioral Health and Developmental Disabilities, and she is an experienced licensed professional counselor. Welcome, Jill. It is my understanding that Vivian is going to present next, and then we will have Rebecca present, and then Jill will round us out at the end. So Vivian, the mic is yours.
Thank you. And it's my pleasure to be here today, and it's wonderful to hear some of the themes that are important to me that have already been introduced. So this is great. Let's have the first slide. Next slide. So some of you may remember the Apollo 13, Houston, we have a problem. Well, I'm submitting to you that America, we have a problem. We have a problem when we have a situation in which the ACLU files a suit over police response to mental health crisis here in DC, where I'm from, because of poor response by the police to persons with mental health crises, particularly in communities that are predominantly Black. America, we have a problem when the CDC reports that our LGBTQI plus high schoolers are 5 times more likely to attempt suicide than their heterosexual counterparts. America, we have a problem when we have a report from the Pew Foundation that documents that there is a higher percentage of people who are white and college educated who know about the 988 system than those who are Black or Hispanic. And then, another concern that they raised was that when they asked the question about whether or not they would use a 988 system, some were not sure because of concerns around police involvement or being forced to be in hospitalization, or that they would have to pay for services. We have a problem. But America, we do have some solutions. So we do have communities with crisis intervention teams. We do have communities in which there is a pairing of police and mental health providers. We have communities in which there are mobile crisis centers. And as you've already heard, we have 988 lines that are in Spanish that facilitate special acknowledgement for those who are in the LGBTQI plus community that are made accessible to those with hearing challenges. So those are really wonderful things. But America, our solutions don't always solve the problems if the mental health practitioner and the police who go together are still walking around with racial bias in their heart or anger about the immigrants in their community. We still have to find ways of building in equity in terms of all aspects of our communities. Next slide. So I'm going to start off with a Vivian story. I have this way of thinking about the obligations of behavioral health systems to you and to me. First, that if I'm in distress, the issue here is around we want the system to be able to respond to the emotional distress, to relieve those physical signs and symptoms, to resolve difficulties in the interpersonal relationships, to restore my functioning in my role, and to also restore me to my mainstream community and my cultural community. If we think about the specific issues around crisis behavioral health systems, I'm saying first and foremost to preserve life, to give people the opportunity to discover something that will give them hope, to establish safety of those who are in this vicinity, in the area, in the home, in the house, in the neighborhood, in the community. And most importantly, for those systems to be a bridge to hope, the hope that will bring the person toward recovery, the hope that will bring a person for relief from the dark demons of the voices that they've been hearing. It is a very personal struggle. The permission, the permission to be outside of an abusive household. The hope. If that's going to happen, please let's have the next slide. There are some responsibilities of those systems. And basically to facilitate and support the interactions between the practitioner, whether this is behavioral health systems in general, the therapists, the counselors, or whatnot, and the individual and or the family or the chosen family, and to promote the attainment of goals comprehensively, timely, with minimum burden. And we're thinking about crisis behavioral health. It's important that we think about achieving sufficient stabilization and engagement and cooperation to enable that next step for healing to occur. But if I cannot connect with you culturally, if I cannot do that, if I don't understand what is holding you back from accepting the opportunity to leave this abusive relationship, oh, it's your faith that's keeping you away. If I can't understand that, then I may not be of value to you. Next slide. So this is really where we talk about the importance of equity. And I'm just going to highlight some of the key words in SAMHSA's definition for equity. The first key word I want to highlight is the right. The equity is the right, the entitlement. It is a statement of justice for all individuals. And you see the listing of access to high quality. Another keyword, affordable services and support, with a goal toward ensuring that the person has the opportunity to be as healthy as possible, recognizing the importance of the social determinants of health, all of which have an impact on behavioral health outcomes. We have work to do. This is multifaceted in so many ways. Next slide. Now, I do want to remind many and inform some that when we talk about equity, we are not talking about equality. So let's look at this next slide. Here's an example of equality versus equity. Bicycles, all the same size. We'll make the assumption that this is a family going for an outing. And we see the struggle of one person in this family who is in a wheelchair and can't even get on that bicycle. And dad's so tall that he's hunched over, and little one so small can barely touch the pedals. Mom is doing all right. This is not an equitable situation. This is a equality situation, but it doesn't solve the problem. Now, when we look at equity, we see that there's a tailoring of the mobile device that each member of the family can use so that they can enjoy this outing. And that is part of our system charge to really create the multiple ways in which people can interact with our services such that they get what they need, their lives, safety, and hope. Next slide. Now we're talking about equity, but we need to understand the flip side of equity, which is the disparities. Because it is the disparities that create the gaps that we need to create elements to achieve the equity that we speak of. So next slide. I'm going to talk first about different types of disparities that we see from the health literature. One type of disparity relates to the disparity in supports and services. So we're looking at the things that are not related to needs or preferences, but because of the nature of the system, whether it's discrimination, bias, insurance, eligibility, access issues, or qualities yields a different outcome based on cultural identifying or marginalized population identifiers. Disparities in health status is more of what we're seeing when we talk about the incidence or prevalence, the burden. It is that data piece that spoke to the difference in the experience of our high schoolers based on their sexuality. Two very different pieces and requirements of different responses from our service systems. Our work lies over here to have an impact over here. Next slide. Frankly, I have no idea where this graph came from. I will say that it tells the story that I think is so important. And that's when we talk about our interventions to address disparities. Oftentimes I'll hear it said, well, we just want to make sure that people have access to quality care. And so we can go for quality, but what if that quality is really still based on European or middle class or the American model, the suburbanite? Suppose that becomes the definition of quality. Well, people may get better, and if this is population blue and population orange and population gray, they're all getting better. But note that the disparities in terms of where they are still exist. Let's go to the next slide. Here we have population blue, orange, and gray. They are getting better, but what's different is that here, blue and orange, the gap is closed. And even the gap between these other populations in gray is narrower. And so we need to think about what are the interventions that we can apply that will promote everybody getting better, but also diminishing the gap between populations. So were there culture-specific interventions involved? Was there more community engagement in terms of developing the appropriate strategies? What was involved in terms of making this difference so that this blue population and the orange population are now pretty much at the same level of outcome? What can be done next to really bring all three groups to the same level? That's our work, to improve everybody and still make sure that there is not the gaps between populations. Next slide. So let's look at culture a bit more. Okay, next slide. Want to remind folks of our definitions of culture. Too often, when people think of culture, they stop with race and ethnicity. They may add language or nationality. But I'd like for you to really think about culture less about identity, a cultural identity, and more about what culture is. It is how we live life. It is what we do every single day. We all are living our culture. It is learned from our infancy, our family, our network, all the information that is assaulting us. I will use the word assaulting us from so many different sources. But what's key is the shared knowledge of the group and the interpretation of the world through that group that gets expressed in guidance on our relationships, our languages, our manners of interacting, our rituals. All of those things are part of what links us to the group and says, this is how I am, this is what is important, this is why the woman in her faith community that says one must submit to the husband feels that it is impossible for her to leave, and in her despair is suicidal. Because the message in that cultural group had something to say about what it is to be in the role of wife. Next slide. So culture informs what the it is to be called a problem. I remember in my own neighborhood that there was a person who would be walking the street. She was okay. She had a place to sleep. She had a place to eat. But she was always talking to folks that we didn't know who they were. And all of that was okay with the community. There was not a sense of, oh, we need to make sure she gets treatment. There was not that sense in the community. Without evidence, but I think pretty sure, if she picked up an axe, I think that's when the community would say, oh, now we have a problem. Now we have a problem. But it's the cultural frame that alerts the community as to when it is a problem. And that becomes a struggle for all of us to understand. But yet, that is one of the factors that we must acknowledge and accept, that there is a cultural frame about when it is a problem. Culture also informs who the appropriate helper should be. Now, I think it's generally understood, and I speak a lot from the perspective of African Americans or Blacks in this country. That is who I am, and that is my natural go-to. And I would say that within my community, that there are ambivalent at best relationships with the police systems. And so the police presence for a crisis becomes problematic. Police presence in a crisis becomes problematic because of that history. And what the helper should do. Many times the reports that I see speak about the need for help in restraining the behavior and calming the person down. That the helper should be calming the person down. Culture may inform what the goal should be. So there are some cultures who believe that evil resides as spirits inside the body, and what the goal of help should be is to release that evil spirit from the body. There are many ways in which culture shows up in terms of what it is, what the appropriate help should be, what the helper should do, and the goal. Next slide. We also need to be attentive to the fact that there are multiple cultural identities. So I'm woman, I'm African American, I'm college educated. Each of those groups, there's a cultural world around those that need to be addressed. But I'm also experiencing sexism as a woman. I'm also experiencing racism as an African American, and as an African American woman, I am dealing with the issues of the intersectionality of these two oppressions. And it shows up in terms of the ways in which the mental health issues are perceived and addressed. If I'm a strong Black woman, I'm not supposed to need help. And so I hold it in forever, 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 until it explodes into a crisis. When I explode into a crisis, I may discover myself to be within the frame of now the angry Black woman. And then there's attitude about how I am received, treated, perceived. Let's move on. We talk about this other frame. So as we look at the individuals, but the individual lives in communities. It's within those communities that we see what's nurturing and what's not nurturing. Unfortunately, those who live in the marginalized identities are also persons who often find themselves living in under-resourced communities. And in those under-resourced communities, we see poverty, poor education, housing insecurity, food insecurity. And the implications in living in those environments is that there are reduced options, the risk of poor choices, the risk of high-risk behaviors, and clearly more stress. This is a place for our intervention. Let us move on. Next slide. Our communities are full of institutions, behavioral health, school, transportation, faith, housing, employment, criminal justice, recreation, developmental disabilities, primary care. Each of those institutions contributes to or facilitates harm or resolving the harm that we may experience in our world. I cannot tell you how many care plans a single family may experience, some with differing goals and objectives, differing qualifiers, that adds to their stress and distress as they move forward. Next slide. So as we think about disparities, let's think about other elements that are important to our understanding. Is there a disparity in availability? So, crisis mobile services, what a wonderful resource. Is it in my neighborhood? Okay, let's assume that it is. Does the neighborhood actually know that it's there? Does my cultural community know that it's there? Accessibility. That relates to the ease and convenience, in this case, of they're actually obtaining and using the service. Go back to the picture of the family. Is it available to those who have physical disability? Is it available to those who have invisible disabilities? What is the accessibility of those services? Hours of service availability, all of those kinds of things are important in terms of the actual convenience of the service. It's great if we have a mobile team, right? That makes it so much easier. But if it's something where somebody has to go to a center, a clinic, that may be another problem. Affordability, what's the cost? Appropriateness, we're talking about, again, quality pieces. But then it has to be acceptable. Is it congruent with the cultural beliefs and values of the person involved? Next slide. As we look at disparities, there are many factors that are involved. There are the interpersonal barriers, the systemic and institutional barriers, as we mentioned. We've talked about the social determinants, and we've talked about cultural group factors that involve and contribute to our understanding of why the disparities exist. And it also leads us to think about where our interventions should and could be. Next slide. So as we think about, as an example, those interventions, just remember that the core work is an interpersonal work. It is the work between an individual who is responding to a phone call and a person or family member or a friend or someone, but it's another person on the other side of that phone. In a face-to-face encounter, it could be the police, it could be emergency medical team, it could be mental health practitioner, right? People are interacting with people. Our client, consumer, person in distress is a member of a family or network of some sort, in a community of some sort, society, all influencing why that person is there and what is and how that person is experiencing the presence of other people in their sphere. But the practitioner too is a cultural person, also from a family, also dealing with colleagues in an institution, all with values and beliefs and practices, worldview, all of that within the society. So this little formula at the end talks about an intervention that's being delivered by a practitioner within an organization that has its own climate and culture, and how that intersects with the client and the client in a network within the social determinants of health setting. That is what winds up to be the ultimate treatment. How all of those factors intersect with each other. Look at the opportunities for our interventions and planning. Next. When we look at our systems, we have to look at the policies. We have to look at the administrative structures and procedures. And of course, the direct interventions. But clearly, we have to have community engagement. All of those pieces together, again, are part of our intervention, the way that we build equity into our systems. Lastly, we talk about the importance of the social determinants of health. We need to build healthy communities. We need to engage our communities in the process of identifying what makes that healthy. Eventually, that goal will lead us to a place where there's a reduced demand for services and makes it easier to enable effective intervention when intervention is needed. So that, my friend, is our overview, major pieces, and a lot that I'm sure that you will receive as you go forward in this series. And I want you to be listening to our next speaker for all of the ways in which the programs that are out there now begin to touch on these and other factors in relating to equity. Thank you. I will turn it back to Laura.
Thanks so much, Vivian, for your wonderful presentation, insightful. I want to now introduce our next presenter. Our next presenter is Rebecca Boss, and she is a distinguished TAC senior consultant, renowned for her leadership in behavioral health care, particularly in addiction and recovery solutions. Her collaborative efforts with the National Governors Association have resulted in groundbreaking publications such as the technical brief entitled Behavioral Health Equity for All Communities, offering actionable policy solutions to advance equity in crisis response. Additionally, her work with the National Association of State Mental Health Program Directors on the technical brief addressing substance use in behavioral health crisis care, underscores her commitment to integrating substance use considerations into crisis response system planning and implementation. I'm going to turn it over to Rebecca now, and then following Rebecca, we will have thought exchange, and then Q&A. We'll combine Q&A and office hours together. Rebecca.
Thank you, Laura, and thank you for that introduction, and thank you, Dr. Jackson, for that very powerful presentation that I now have to follow. As stated, my name is Rebecca Boss. I use she, her pronouns, and I identify as a white woman. Now that statement might make some people feel uncomfortable, like, of course she's a white woman, but I think when we're talking about cultural responsiveness and equity and disparities, assumptions are part of the problem, and I think we need to identify that up front. And, you know, while you have my bio, I just want to say that I am a person who once held a position of power within a state's behavioral health care system, and I thought that I was pretty successful in community engagement and health equity strategies. And then I went to work for an organization that really had a strong commitment to diversity, equity, inclusion in both our internal operations and in our external work, and had the opportunity to learn from some really amazing colleagues. And so I soon became aware that it's what you learn after you know it all that counts. And I am still learning, and I appreciate the opportunity to share with you what I've learned thus far. So next slide, please. Dr. Jackson shared this distinction with you earlier. This is another visualization, but I think it's important to reemphasize that while both equity and equality aim to promote fairness and justice, to be truly equitable, we need to recognize that not everyone is starting from the same place. Next slide. And again, Dr. Jackson addressed health inequities earlier, but it's important to emphasize that groups of people that have been historically marginalized, excluded, and discriminated against have systemically experienced greater obstacles to health, are exposed to conditions that negatively affect health, and have higher rates of health disparities. So these groups include Black, Indigenous, persons of color, lower socioeconomic groups, rural, disabled, and LGBTQI plus populations. Next slide. And specific to behavioral health, inequities show up in the rates of these groups that access treatment, when they initiate treatment, premature discharges, the burden of the disability, experience of stigma, receipt of life-saving medications, likelihood that they'll experience crisis and become incarcerated. It's really important to note that unmet behavioral health needs due to compounded inequities can exacerbate an individual's condition to the point of crisis. Next slide. Dr. Jackson discussed the 5 A's plus 1 in consideration of health inequities. If we start with lack of access to culturally responsive care, we see how this inequity can play out and create a cycle of oppression for individuals, groups, and communities. If behavioral health needs aren't addressed, the likelihood is that these conditions will worsen to the point of crisis, likely. And if a behavioral health crisis in a marginalized community most likely results in a public safety response where police or EMS are going to respond as opposed to clinicians or peers or some combination thereof, the likelihood of that crisis event resulting in a negative outcome, hospitalization, incarceration, or even death increases. Then we know that events of hospitalization and incarceration can create trauma. They can impact work, health, home, family supports, etc. Those negative stressors increase the likelihood of behavioral health symptoms, which are again not adequately addressed due to inadequate access to affordable, acceptable, and appropriate care. So we see this cycle play out in ways that continue to promote inequity and negative impact of crisis. So we have an opportunity to intervene at each stage of this cycle, really looking at crisis care as a continuum not just event. Next slide, please. So across the crisis continuum from pre to post-crisis, culturally responsive care, which makes care more acceptable and more appropriate, can have an impact in reducing disparities. So in SAMHSA's model of crisis response, someone to talk to, someone to respond, a place to go, each of those elements needs to be safe for the individual, incorporating understanding of and appreciation for various cultures through culturally responsive care that helps to create a safe space. Next slide, please. So the concept of culturally responsive care is not new. Almost 25 years ago, the United States Health and Human Services Office of Minority Health released the national standards for culturally and linguistically appropriate services, class standards, designed to advance health equity, improve quality, and eliminate disparities by giving a blueprint to healthcare organizations. Now, I will note that this slide and the next break every rule of PowerPoint slide making. They're too busy, they have too much information, and I'm not going to go over it all, but note that you'll have these slides available to you later on. CLASS consists of 14 standards and one guiding principle, which is this: provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. And then the 14 following standards are broken down into the areas of governance, leadership, workforce. Next slide. Communication and language assistance and engagement, continuous improvement, and accountability. So as I said, I'm not going to take the time to review these standards, but it's important to note that they do exist and they have been in place for some time. Next slide. So for the rest of this presentation, what I'd really like to present is a framework for states and providers to consider cultural responsiveness across the crisis continuum. Next slide. First, we would start with the system that exists. States and providers can take action to ensure that the current system is more responsive to diverse groups and cultures. For states, are providers encouraged and or required to implement class standards? Is there oversight? Who provides that oversight? Who should provide that oversight? Is training available? Are there efforts to support diversity in the workforce? Is it funded? So for providers, do you implement class standards? Do you seek out training and technical assistance to provide culturally responsive care? Are you creating pathways to recruit and retain a diverse workforce? Next slide. So there are state examples of what is happening in this lane. Some state examples of providing the existing infrastructure are here, and one state that I might highlight, again, this is too busy, but California requires each county behavioral health department to develop and update annually a cultural competency plan that's aimed at reducing behavioral health service disparities in underserved populations. And in 2019, California legislature passed legislation funding a multi-agency government collaborative, which provides no-cost training, technical assistance, and supportive resources to county behavioral health agencies and community providers. Next slide. So the next strategy in this framework is to expand the service delivery network to include non-traditional partnerships. Small grassroots organizations deeply embedded in their communities may be well suited to respond to the needs of their communities, but face challenges in gaining financial and other supports from state and federal government. They also face challenges in establishing meaningful partnerships with the existing system. So states can undertake many activities designed to engage these community-based entities as critical system components, as outlined on this slide. Providers, too, can benefit by establishing formal and informal connections to non-traditional partners within the communities that they serve. Next slide. And this is another slide that breaks all the rules, but provides you with good examples of strategies. So I just want to talk about a few. So in rural communities, underserved communities, the Alaskan Native Tribal Health Consortium created the Behavioral Health Aid Program to promote behavioral health response services within the Alaskan Native community by providing behavioral health training and certification to individuals residing in the tribal communities across the state. In the area of technology, providers in states such as North Dakota operate telehealth outreach programs to provide trauma-informed behavioral health care services to youth and families who have been exposed to trauma in order to mitigate the impact and prevent escalation to the point of crisis. And then with trusted community partners, based in Little Rock, Arkansas, the Confess Project trains barbers to be mental health advocates, cultivate a culture of mental health, recognize signs of acute behavioral health concerns, and coordinate with local behavioral health entities to support Black men and boys in connecting to appropriate services. Next slide, please. The next strategy within the framework involves establishing governance structures that include persons with lived experience. This really recognizes that the people who are most impacted by the problem are often closest to the solutions, but have the least amount of power. And this really requires intentional and authentic community engagement, not just checking the box, not just listening to the folks who show up or who are the loudest. Engagement really requires active support and strategic partnerships with communities. For providers, it's crucial that these organization strategies are informed by those that are served, and that leaders actively seek to incorporate voice and identify resources that will support the work. So the next slide identifies again examples of states that have engaged the voice of lived experience, and the one that I'll note related to 988 is Washington's 988 legislation that required various entities, including tribal nations and including people with lived experience, to participate in crisis response improvement strategy committees to ensure multifaceted system planning. The state created planning committees focused on enhancing accessibility to ensure individuals receiving the services are actively shaping the system and remain engaged in its evaluation. Part of the importance here is that engagement of people with lived experience is present from the beginning of planning through to evaluation. It's not a strategy of checking with the voice of lived experience really after the decisions have been made. Next slide. And finally, for a strategy framework to be effective, it has to be supported by data, and the data needs to be transparent. States and providers need to know what information will inform their system design, where and how those pieces of information can be attained. Progress needs to be tracked, progress needs to be shared. And data tells a story, but it needs to be accompanied by narrative that incorporates various viewpoints and experiences. Data alone in a vacuum is not necessarily useful. So slide 16 demonstrates some ways that, the next slide, I'm sorry. Again, there are many examples of communities, cities, and states that use data in a way that the public can see and inform strategies. So the Tucson, next slide, sorry. The Tucson Police Department created a public-facing dashboard which allows community members to explore and review policing statistics. So behavioral health authorities can take similar measures in order to create public awareness of their efficacy of their crisis response systems. Authorities, many states like Virginia had COVID-19 response efforts that created the opportunity to use data to inform health equity and health inequities and to share that information publicly. The state of Rhode Island, where I have worked, is very active in sharing its information related to strategies to inform the opioid overdose crisis response and putting that information in a dashboard so that the community has access to the information that can be in fact impactful and helpful in terms of the strategies to respond. So in conclusion, I know that was a lot, and between the two presentations, it was a lot of information to be given to you. But really, this is an overall framework that provides an outline that can help to shape the embedding of equity across the crisis continuum. And I hope that it's helpful with you as you move forward in this work. And I turn it back over to our colleagues at Samson. Thank you.
Great. Rebecca Boss, thank you so much. That was just full of information. And what I think I really appreciated, because I learned so much in all of these presentations, what I really appreciated is the state examples and pulling some of the frameworks that we've used historically to use into embedding equity in our crisis response system. And so you've spent some time listening to SAMHSA and their vision and their foundation for this work. You've spent some time listening to Vivian help us really understand why we need to pay attention to culture and social determinants of health and structural and systemic factors, and why if it isn't appropriate and acceptable and affordable and accessible for the folks who are interacting with the system, then there will still be disparities. And so we have our work cut out for us. It's time now to hear from you. And I just want to take a moment to say, we know that we're a little bit off schedule, and that's okay, because that content was so rich and so important. What I'm betting is that you're thinking about all of the different people in your systems, all of the different conversations that you might want to have in order to move your work forward in your community, your state, your tribe, or wherever it is that you're embedding equity in your crisis response system. So I want to take a moment to provide you all an opportunity to send some of your thoughts our way. We have something called, actually, I'm going to share my screen right now. At least I thought I was, but then I didn't. Sorry. Take a moment. Sorry about that. I can't get to the screen sharing piece. There it is. Okay. Thank you for your patience. I am very excited to launch this thought exchange with you all. And the first thing that I want to do is direct your attention to this question. And while I'm giving you some instructions about how this will work, I want you to be thinking about what conversations are the most important for you to have as you embed equity into your 988 crisis response system. Again, what are the conversations that are the most important for you to have, no matter where you are in your journey as you embed equity into your 988 crisis response system? So this is a little bit like a survey meets a focus group. It's an opportunity for you to log on to this platform in two different ways, the QR code, or you can go to tejoin.com and use this code to get into the thought exchange. It will ask you a few questions, but please know that your answers, your thoughts will be anonymous. We will ask you to give one thought per opportunity. So please don't give us 5 thoughts at once, because it helps us, it gets in the way of organizing. So if you could give us one thought, and then tell us why your thought is important to you. Why is that thought important? And there's a timer here. I would love for you to spend a couple of minutes just giving it thoughts about those conversations that are the most important for you to have. And then about halfway through or so, you'll get the opportunity to start seeing the thoughts of others. And it will ask you to give stars to those thoughts. So you might need to have a conversation about who's not calling 988. For example, I'm just throwing that out. That's a conversation that you need to have. And you might see that thought come up and say, well, we've already had that conversation, so that's not as important to me. I'll give that a 3. But if that's something that you haven't had and that's really important to you, please give that 5 stars. What this will do is organize all of those thoughts and all of those stars, and we'll be able to see the top starred thoughts and the thoughts that most people had pretty instantaneously. And then, so just so you know what we'll do with the rest of this data, we'll organize it through thematically, and it will provide us at the TA Center and at SAMHSA an opportunity to get a sense of where you are in your journey, what conversations you need and want to have, and it will inform our learning collaborative, our convening, and the listening sessions and the other TA work that we're doing. So without any further ado, please go ahead and log on. I see 37 participants already there, so that's great. And I'll start the timer, and I'll just check in with you in a few so you can start rating if you haven't already. Okay, 4 minutes goes quickly when you're writing thoughts and responding to the thoughts of others. I just wanted to show you a couple of them that got a lot of stars. So the first one was how to build the connections between 911, 988, and 211 so that callers' needs are being met at the most appropriate level with the least amount of risk. We know 911 has been overutilized. Ooh, and that moved. And that we have the opportunity to do something differently. So looking at equity early is imperative. How can we make sure our system is utilized by those who may be marginalized in the community or maybe in the marginalized community? I don't believe our message gets to them and that they feel comfortable using our services. So there's a lot in here, it looks like, around informing, raising awareness, working with specific populations like the American Indian populations. It's very important to reach out to the elders. Determining reasons for a lack of trust. So it sounds like there's a lot of the conversations you're talking about are about raising awareness, building trust, understanding barriers. And there's a lot of support here also for understanding that equity and culture are essential in this stage of developing this system. So we'll be using this. We'll be looking through it and looking at the themes, and it will definitely guide some of our much of our work in embedding equity. I'm going